Assalamu alaikum again and good evening, everyone. Welcome to PSA Karachi online lecture series. I'm your host for today, Dr. Abdullah Nassar, Fellow Pen Medicine at Al Khan University Hospital. And today we have Dr. Nauman Aqeel with us. Dr. Aqeel is currently working as consultant anesthesiologist at the Department of Anesthesiology, Ziauddin University, Karachi. I would request you all to please turn off your mics and write your queries in the chat box during the lecture, which will be answered at the end of the session. Dr. Noman, please.
Assalamu alaikum, everybody. I am Dr. Nauman, and I'm here to present the topic. I hope you can all hear me.
Yes,
The topic is anesthesia for neurointerventional procedures, which is coiling for aneurysm. Okay. Uh, I disclose that I have no commercial or financial interest in the objectives, content, and delivery of this session. Uh, Neurointerventional procedures are minimally invasive, and it is used to treat cerebrovascular diseases like brain aneurysm, AVMs, and stroke. These procedures are performed by assessing the brain through blood vessels, primarily via the femoral or radial artery. These are just basic things which you all must already know. I'm just going through this. What is a brain aneurysm? A localized bulge in a blood vessel wall in the brain. Can be of three types: secular, berry shaped, fusiform, spindle shaped, or dissecting, which can be a tear in the vessel wall. Intracranial aneurysms have a 3.2 prevalence in the general population. Why is treatment necessary? Untreated aneurysm can rupture, leading to subarachnoid hemorrhage. Subarachnoid hemorrhage has high mortality and morbidity rates. There are two treatment options for this. One can be surgical clipping, and the other is endovascular coiling, which we'll be covering today. This is a comparison of endovascular coiling versus surgical clipping. It is presented in a Cochrane review in 2018. That in all three categories, endovascular coiling shows a better outcome. 1 year poor functional outcome, coiling has only 24% poor functional outcome, and clipping 32%. Likewise, delayed cerebral ischemia and rebleeding, coiling has fewer complications compared to the clipping. Treatment preference. Surgical clipping are preferred when large intraparenchymal hematomas can be found, when the aneurysm includes middle cerebral artery, or patient unlikely to comply with the follow-up. Endovascular coiling can be done in geriatric patients or with high-grade subarachnoid hemorrhage. Early management goes in aneurysmal subarachnoid hemorrhage. First of all, we have to maintain oxygenation and ventilation. It is very necessary to rapidly restore cerebral perfusion. We have to prevent rebleeding, initiate seizure prophylaxis if indicated, start nimodipine therapy, or plan for definite treatment. Hypoxia and carbon dioxide imbalance worsen outcomes. Hypoxia increases mortality. Hypocarbia causes vasoconstriction, which can worsen ischemia. Similarly, hypercarbia causes vasodilation, which increases ICP, which both can be bad for the patients. Ventilation ensures patent airway and adequate oxygenation. Intubate only if comatose or unable to protect airway. Hypoxia, when patient is facing hypoxia or hyperventilation, or they are hemodynamically unstable. Rapid restoration of cerebral perfusion. There's a role of external ventricular drain, which is usually called EVDs. It is used to treat hydrocephalus and restore cerebral perfusion. It facilitates aneurysm clipping by managing ICP. What is the indication for EVD placement? If the ventriculomegaly with GCS less than equals to 12 or Hunt NS is greater than or equals to 2. It is important it avoid rapid CSF drainage, because rapid CSF drainage prevents rebleeding. A monitor for persistent deficits, consider seizures. Prevention of rebleeding. High risk period and factors. 4 to 13.6% risk in first 24 hours. Risk factors are loss of consciousness at onset, delayed treatment, sentinel headaches, large aneurysm, and or systolic blood pressure if more than 160 mercury millimeter of mercury. It is very necessary to manage the blood pressure. There's a very strict BP control. We have to keep the systolic blood pressure less than 160, but at the same time we have to avoid hypertension. So we should not go the CPP below 70 millimeter of mercury, because it may cause brain hypoxia. Preferred agent is short acting antihypertensive like nicardipine or esmolol. If the patient is on anticoagulant, so we have to reverse the anticoagulant, or we can use short-term antifibrinolytics like transamines if the treatment is delayed. So it has a very good role during the period if the definite treatment is delayed. Uh, it does not increase the risk of ischemia, but there's a risk of DVT. Seizure prophylaxis. Seizures may worsen neurological injury and trigger rebleeding, but there is no universal consensus on routine prophylactic anticonvulsants. When can we consider prophylaxis? If the patient have poor neurological grade, unsecured aneurysm, or associated intracerebral hemorrhage. Early initiation is reasonable only in high-risk patients. As it is also given in AHA guidelines of 2023 for subarachnoid hemorrhage, that in patient with subarachnoid hemorrhage and high seizure risk, like ruptured MCA aneurysm, high-grade subarachnoid, or hydrocephalus or cortical infarction, use of prophylactic anti-seizure medication may be reasonable to prevent seizures. But if the subarachnoid hemorrhage is without high risk, so it can be avoided. There is no benefit indicated in the guideline. Vasospasm. It occurs in 20 to 30% of subarachnoid hemorrhage patients. It rarely occurs immediately after subarachnoid hemorrhage. It it starts mostly after day 3, peaks at day 7 to 8, and it may last up to 21 days. It may lead to delayed cerebral ischemia. Uh, a fluid goal should be to maintain euvolemia to reduce ischemia risk. Avoid hypovolemia, which increases the risk of cerebral ischemia, and now it is also indicated to avoid hypervolemia as well. As this is given in the guideline that in patient, it is a level 2A recommendation that in patient with subarachnoid hemorrhage, close monitoring and goal-directed treatment of volume status are reasonable to maintain euvolemia, and it is harmful to induct of hypervolemia is potentially harmful because of the association with excess morbidity. Uh, as we can see that we used to follow the triple H therapy prophylaxis, but there are multiple studies. This is one of the study in which shows that triple H has multiple harmful effects. So we have to avoid hypervolemia. We have to maintain a good euvolemia, and uh, it is very important to avoid hypertension as well. We have to have a good blood pressure management. We should avoid hyper and hypertension both as well. Nimodipine, it improves its outcomes in subarachnoid hemorrhage despite no clear effect on vasospasm. Uh, Possible mechanisms are dilation of smaller arteries, reduction of calcium-dependent excitotoxicity, and it also decreases platelet aggregation. The dose is 60 milligram orally or via NG tube every 4 hours. Start within 48 hours of subarachnoid hemorrhage, and it can be continued till 21 days after this hemorrhage. The level 1 recommendation to start early initiation of enteral nimodipine is beneficial in preventing DCI and improving functional outcomes. And the rest is all about to maintain the blood pressure and maintaining euvolemia during this. There's a Cochrane review in 2007 that's calcium antagonist for aneurysmal subarachnoid hemorrhage. 16 trial involving 3 to 6 month patient were included in the review, and it shows calcium antagonist reduced the occurrence of secondary ischemia and showed a favorable trend for case fatality. Pre-anesthesia evaluation. Uh, Facilitate early definitive treatment with a targeted evaluation. Uh, Assess clinical grading. We can assess the patient by Hunt-NS scales or WFNS grading system. We have to identify risk factors like intracranial hypertension, cerebral ischemia, or intraoperative brain swelling. The commonly used grading scale Hunt-NS. It is divided into 0 till 5. 0 इज अनरप्चर्ड एन्यूरिज्म. जैसे जैसे आपका हार्डनेस बढ़ता रहेगा, पेशेंट के जो सिम्टम्स वो और खराब होते जाएंगे, लाइक एसिम्टोमेटिक से मॉडरेट टू सीवियर हेडेक है, न्यूक्लियर रिजिडिटी है, बट नो न्यूरोलॉजिकल डेफिसिट अदर देन क्रेनियल नर्व पैल्सी, ड्राउजीनेस, कोमा. सिमिलरली WFS जो है वर्ल्ड फेडरेशन न्यूरोलॉजिकल सर्जन्स, उसमें मोस्टली डील्स विद द GCS. GCS 0 है, विद GC 1 होता है GCS 15 के साथ, और फिर जैसे जैसे GCS आपका ख़राब होता जाएगा GCS then the so it is a level 1 recommendation to use of clinical scales like Hunt-NS or WFNS is recommended to determine initial clinical severity and predict outcome. Cardiac considerations. There's a risk of stress, cardiomyopathy, and arrhythmias. We can see the ECG abnormalities after SAH like sinus brady, tachy, QTC prolongation, ST depression, or T wave inversion. But these are due to the neurological deficits, neurological issues, which is because of the hemorrhage. So urgent surgery should not be delayed for ECG changes in stable patients. If the patient is stable, we cannot delay the surgery because of these cardiac changes, because these cardiac changes are related to neurological symptoms. Elevated troponin I and BNP level reflects myocardial stunning. Supportive management with careful use of inotropes. Pulmonary complications occur in up to 22% of patients. Neurogenic pulmonary edema, pulmonary embolism, aspiration pneumonia. Neurogenic pulmonary edema more common with posterior circulation aneurysms. It can be caused by sympathetic surge and inflammatory response, elevated plasma norepinephrine and epinephrine, possible brainstem irritation triggering lung dysfunction. Metabolic and electrolyte management. We have to maintain hyper and hypoglycemia. We may need insulin administration. We have to avoid hyponatremia and hypernatremia at the same time. If there is hypokalemia, so we have to correct it before surgery. Monitor electrolyte and osmolality due to mannitol or hypertonic saline. Perioperative monitoring and imaging. Review CT for hematoma volume, sulcal effacement, midline shift, or hydrocephalus. We also have to review cerebral angiogram for aneurysm details and collateral circulations. So as we are doing this procedure outside the operation theater, so it is very important to know your playground. Like you have to determine layout out of room and anesthesia machine position, expected fluoroscopy machine movement, availability of protective lead aprons on screens, ensure full range of motion without interference from lines or tubes. Equipment and monitoring. Position anesthesia machine to one side, possibly without airway access. Use extension for IV tubing, arterial line pressure tubing, or breathing circuit. Secure monitors and breathing circuit away from the radiographic field. We have to prepare normal GA drugs as we prepare for any other procedures, but we have to keep additional drugs ready we have to keep with us phenylephrine, nicardipine, norepinephrine, vasopressin, and protamine for heparin reversal in case of aneurysm rupture. For patients on dual antiplatelet therapy, prepare platelets for potential hemorrhage management. If we have elective aneurysm procedures, we can use midazolam 1 to 2 mg to provide angiolisis and patient comfort. But if the patient is after subarachnoid hemorrhage, so we have to tailor medication based on the patient's mental status, and we have to avoid excessive sedation if the patient has altered consciousness. A goal of induction of anesthesia is to prevent hypertension during laryngoscopy and during intubation, because hypertension can increase the risk of rebleeding. What will be our strategy? Strategy is simple: just to keep the anesthesia deep. We can use fentanyl or remifentanil. We can use short-acting antihypertensive like esmolol. Uh, we can do rapid sequence induction if nausea, vomiting is positive, and succinylcholine is safe after ensuring adequate anesthetic depth. Avoid both hyper and hypertension. Hypertension can increase the risk of ischemia. Hypertension can increase the risk of rebleeding. We can use pre-induction arterial line, but it is not always necessary. We have to make our judgment according to the patient's condition and patient other comorbidities. Non-invasive BP monitoring can be sufficient. Monitor BP before and after induction, before laryngoscopy, and post-intubation. In ventilation, we have to avoid extreme CO2 changes, as hyper and hypocarbia can be harmful for the patient. Hypercarbia causes vasodilation, which can increase the ICP, or hypocarbia, which decreases the ICP and which increases the transmural pressure, which further increases the risk of rebleeding. Monitor ICP if EVDs is in place, and red flags after intubation is sustained hypertension or bradycardia and new onset pupillary asymmetry, which can be a suspicion of rebleeding. Brain trauma, according to Trauma Foundation, there is a level 2B recommendation that prolonged prophylactic hyperventilation with partial pressure of CO2 of 25 or less is not recommended. So we should not go below 30 millimeter of mercury. 30 to 35 is ideal for these cases. What is the goal of anesthesia? And basically, ideal anesthetic consideration. What anesthetic we should be used? The goal is to reduce the cerebral metabolic rate, avoid intracranial hypertension, maintain adequate cerebral blood flow and hemodynamic stability, provide neuroprotection, and allow rapid emergence. Avoid interference with neurophysiological monitoring. Some effect of common anesthetic agents, like we usually use isoflurane, so it decreases the CMRO2, and there's a little increase in ICP and CBF. Similarly, we can see that dexmedetomidine is ideal for this situation, that it reduces the CMRO2, reduces ICP, reduces CBF, and reduces cerebral blood volume. Propofol similarly is a very neuroprotective medicine which we use for the induction of anesthesia, and opioids have no effect on this. What should we use? IV versus inhaled anesthetic. Propofol maintains CMR and CBF coupling, which reduces ICP. Inhaled agent, if less than 1 mag, it reduces cerebral blood flow, and if it is greater than 1 mag, it causes cerebral vasodilation. High dose desflurane improves brain oxygenation, and it can worsen brain swelling in low compliance states. There are multiple studies to compare the role of propofol and volatile agent for maintenance of anesthesia during elective craniotomy and other procedures, but we couldn't find any difference between the two. There's a recent study in 2022, propofol-based anesthesia maintenance and or volatile anesthetic during intracranial aneurysm. So it said that despite the theoretical advantage of combining volatile anesthetic with propofol for anesthetic management, our data support the use of only volatile anesthetic for both endovascular and open UIA treatment and showed no benefit of addition of propofol infusion. So it shows no difference. We can use either. We can use inhalational agent or we can use propofol as well. Neurophysiological consideration, propofol does not affect HCCPs. This is more important for the clipping. Dexmedetomidine reduces anesthetic needs and blunts hemodynamic responses. May interfere with MEPs. Avoid if more than 0.4 to 0.5 mics per kg per hour. Effect of supplemental dexmedetomidine anesthesia on intracranial aneurysm patient undergoing intracranial interventional embolization. Dex has been shown to stabilize hemodynamics by activating alpha-2 analgesic receptors. It has been demonstrated that Dex reduces intraoperative adverse action. The result showed that Dex supplementation during anesthesia significantly reduces tachycardia, restlessness, shivering, and cough without compromising long-term surgical outcome. So nowadays it is very a common practice to use DEX throughout the procedure. As you can see that there are many advantages of using dexmedetomidine. Intraoperative, we have to use the standard anesthesia monitors like ECG, pulse oximeter, temperature monitoring, and end-tidal carbon dioxide. In neurocritical monitoring devices, we can use EVD if patient has already placed EVD, so we can measure and manage ICP. Jugular saturation catheter can be used to monitor cerebral oxygenation and detect ischemia. Existing neurocritical care device should remain operational during the perioperative period to optimize patient shift. These are the same things that we have to keep systolic pressure under 160 to reduce the risk of bleeding. It is according to AHA guideline, which was published in 2012. Now in 2023, they again reshowed this that we have to keep this systolic pressure less than 160 and we have to maintain the cerebral perfusion pressure more than 70 millimeter of mercury to avoid ischemia. Preferred short acting titratable IV agents like antihypertensive, nicardipine, labetalol, esmolol, and avoid nitroprusside due to potential risk. In patient with subarachnoid hemorrhage and unsecured rupture aneurysm, frequent intraoperative BP monitoring and BP control are reasonable to prevent ischemia and rupture. And this guideline also suggests that further studies should be done to see the effect of the respective blood pressure to keep the blood pressure in the safe range. Prevent intraoperative brain swelling. We have to maintain adequate depth of anesthesia and analgesia. Keep MAC less than 1 with inhaled anesthetic. May use IV anesthetics if brain swelling is anticipated. We can elevate the head to avoid excessive neck flexion or rotation. Maintain PCO2 in between 30 to 35 millimeter of mercury. We can use medical intervention like mannitol, hypertonic saline, and IV furosemide. It is recommended in the recent guidelines the patient with subarachnoid, the intraoperative use of mannitol or hypertonic saline can be effective in reducing ICP and cerebral edema. Blood glucose management. Hyperglycemia is linked to poor outcomes. Both hypervolemia, hypoglycemia, and hypoglycemia should be avoided. Our target blood glucose should be 80 to 180 milligram per deciliter. We have to monitor blood glucose during surgery. In patient with subarachnoid hemorrhage, prevention of intraoperative hyper and hypoglycemia during aneurysm surgery is reasonable to improve outcome. Optimal glucose target after aneurysmal subarachnoid hemorrhage. This study also suggests that we have to avoid both hyper and hypoglycemia. We have to keep the glucose in a tight range between 80 to 180. Similar with temperature management, mild hypothermia was historically used but showed no benefit in the trials. Induced hypothermia is rarely used in modern practice. Target temperature is 36.5 to 37.5 for optimal patient outcomes. Fever worsen outcome and after stroke and should be aggressively treated. In patient with good grade SAH, the routine use of induced hypothermia during aneurysm is not beneficial. So there's no benefit proved until now of to keep the patient in mild hypothermia. Patients are often heparinized during procedures to prevent thrombosis. Uh, Goal, we have to keep the range for ACTs. It should be established with an interventionist. We have to regular monitoring is essential to ensure therapeutic levels. Intraoperative aneurysm rupture. What are the signs of intraoperative aneurysm rupture? If unexplained increase in blood pressure or increase in intracranial pressure, we have to take immediate actions, rapid decision making on imaging, angiography, or surgery, team coordination to manage the situation. Aneurysmal rupture is rare, but most likely during deployment of the initial coil management, we have to reverse the heparinization immediately with protamine. Thromboembolism is also a potential complication of endovascular coiling. It can be detectable via angiography. We can use efiximab in 0.25 milligram per kg bolus. Then we can start the infusion at 0.125 mics per kg per minute. What is the management after intracranial aneurysm rupture? Optimize cerebral perfusion, allow permissive hypertension, aim for cerebral perfusion pressure 50 to 70 or MAP above 90. Optimize oxygenation and ventilation, maintain PaO2 more than 80 millimeter of mercury in ABGs and PCO2 38 to 38 millimeter of mercury. Administer osmotherapy. We can use mannitol at 0.25 to 1 gram per kg, or we can use hypertonic saline. We have to improve the venous drainage, like elevate the head to 115 degrees and keep the patient in a neutral position. What should we do like the extubation? Should we extubate the patient, or we should keep the patient mechanically ventilated after the surgery? So according to Hunt and Hess grading, if the patient is 1 and 2, most can be extubated post-operatively without airway support. But at the same time, we cannot only rely on the Hunt and Hess grading system, because it is not suggesting anything what we went through the intraoperative phase. So what we went through the intraoperative phase and the other comorbidities of the patient, then we have to decide according to the current scenario of the patient. If the Hunt and Hess is grade 3, may or may not need mechanical ventilation. Grade 4 and 5 usually require post-operative mechanical ventilation with other comorbidities and the intraoperative condition of the patient. Ensure patient is comfortable, avoid coughing and straining, administer lidocaine at 1.5 milligram per kg, bolus to minimize coughing and endotracheal tube reaction. Strict BP control is essential, especially in patients with ischemic heart disease or multiple aneurysms. Maintain BP within 20% of the patient's normal range. That's it from my side. We can take questions.
Thank you very much, Dr. Nauman, for such a comprehensive presentation on this topic. I would like to request the participants that the forum is open for the question answers, and if they wish, they can also type in the questions within the chat box as well.
Assalamu alaikum, Dr. Tahir here from Lahore. Thank you very much, Dr. Nauman. Very comprehensive talk, and you touched all the details. Just two comments. First thing, yes, you mentioned about monitoring and A-line invasive monitoring. I will just suggest to all the participants, usually patient is intubated in ER. Visit the patient personally by yourself and do all the necessary things there in ER, because you have space and you have a little bit time. Intubation, any invasive line, a good peripheral to good lines. Because when you reach the IR suite, the space is very limited. They have their equipment, space is limited, and then you cannot do things there. Second point is a bit tricky about extubation after the procedure. Always consult again and again with the IR people that do they want immediate extubation. So there are two components. One is regarding the surgical side, consult with them. The other component is if intubation was difficult, don't try to extubate in IR suite. Let it to be done in ICU. So these were just my two comments.
Assalamualaikum, Dr. Shehzad from Rawalpindi. Thank you, Sir Tahir, for the addition. And I would like to add, in these patients, there should be a backup plan also. We should also keep some our colleague at the backup because the things they may get tricky, and we should not get in a situation where we are trapped. And the best thing is we should have a plan, and in the planning should include shifting of the patient if required to the operation theater, ICU, and in case if there is some problem, the problems they should be discussed, and all the situations they should be discussed with the patient and their attendants. They should be taken into confidence because if we go to the emergency or IR suite and we start the procedure straight away without informing the attendants or taking them into confidence, then we can land into problems. There is one thing more. When there is EVD in place, then during shifting of the patient, the EVD has to be blocked, and when the patient is shifted to ICU, then the position is again to be adjusted. Thank you very much.
Thank you both of you for your valuable suggestion and advices. Dr. Nauman, there is a question in the chat box. Dr. Hamid from Lahore wishes to ask, while using Presidex, dexmedetomidine, should we be using exclusively the infusion or use it as an adjunct to the inhalational agent?
Okay, to answer the question, I will suggest to use it as an adjunct. In my practice, I use an adjunct, as DEX. Only using DEX will make it a bit tricky to maintain the cerebral perfusion pressure and then the bradycardia. So it is better to use it as an adjunct to reduce the need of the inhalational agents.
Thank you, Dr. Nauman, for the answer. There is another question. Dr. Fahd Tariq wishes to ask to explain what will be the necessary window period for coiling in case the patient is having cerebral vasospasm due to subarachnoid hemorrhage.
There's two things which can be done here. If the patient, if you are sure of the vasospasm, then we can wait for 10 to 14 days. We can start the therapy to avoid the vasospasm. Then we can go for the surgery procedure after 10 to 14 days. But in some cases, if it is required urgently, so we can do the procedure after 1 week, and by treating aggressively our vasospasm.
I hope that must have answered your query, Dr. Fahd. I would like to have Dr. Arslan Jamil, if he's listening, to have some concluding remarks on this presentation. Dr. Jamil is assistant professor at Civil Hospital, Karachi, and his comments would be valuable to this presentation as a conclusion.
Thank you. Thank you for inviting me for giving conclusion on this so very much difficult topic, Dr. Abdullah. This is Dr. Arsalan, and I would suggest all the listeners to maintain all the necessary things that have been discussed in the forum as by Dr. Shahzad and Dr. Tahir. Really, the things are really tricky sometimes. So our senior cover and uh, preparation for providing general anesthesia with all the basic things intact is very, very important. And being prepared and always discuss and communicate all the things with the neuro anesthesia team always. And sometimes communication really helps. And sometimes they want the patient to go directly to the ICU without any execution plan because they are suspecting high rebleeding or something like that. And in our practice, we are just using all these monitors, but I think there will be a time shortly that we will be using the dynamic cardiac output monitors because as far as the goal-directed fluid therapy and the high per volemia exclusion and inclusion of euvolemia these days, I think there will be a lot more to be changed, and I think PSA will be helping all the listeners to be on the right track always. And thanks a lot for allowing me to concluding this session, Dr. Abdullah.
Thank you, Dr. Arslan. Last question from Dr. Rimsha Athar. She wishes to ask Dr. Nauman that most of the patients who are presenting for the coiling are hypertensive and are on medications. So is there a protocol to stop these medications before proceeding for the procedure?
No, there is no such fixed protocol. We have to continue the medication as per the requirement of the patient. Like if they are on a antihypertensive drug, and we want to and we are already maintaining the blood pressure according to our need, because we can't go we can't afford hypotension or hypertension. So at those situations, we have to maintain the blood pressure by ourselves. But like rest of the medication, if there is no contraindication to continue the drug, so we can and we should continue those drugs.
Thank you so very much, Dr. Nauman. I would request all the participants to fill in the feedback form for the e-certificates to be generated to you. And with this, we would be concluding this session. I would again thank Dr. Nauman, Dr. Arslan for their contribution, and also the other speakers who had pitched in to have their comments as well. And that would be it from our side for today.